Hey guys, and welcome to episode 128 of the OCDstories.com podcast. In this episode, I got on Dr. Kevin Chapman for the second time, and the first time, he is an OCD specialist based in Kentucky, and the first time we talked about OCD treatment, OCD recovery. Towards the end of the episode, we also get into sports psychology and kind of break down some of the learnings from that and how that could potentially help people with OCD. But Kevin has also done a ton of research and studies on how culture affects mental health, as in how people of different cultures going to therapists and clinicians of different cultures are affected, meaning treatment outcomes, whether they get the right diagnoses. For example, some people will share symptoms and experiences differently from another person of a different culture, because that's kind of their underpinning and their framework in which they operate. And the studies show the kind of impact of therapists not having a cultural understanding. So I want to do this episode to kind of increase awareness for therapists, and hopefully you guys, therapists listening, will learn something. I learned loads out of this. Kevin really opened my eyes to some areas, and also for those with OCD who feel they have a different culture to maybe the therapist they're going to. Hopefully this can help empower you to make good choices in who you pick, and also with work better with your therapist so they understand your culture better and you're getting the most out of treatment. Kevin was the right person for this episode. We cover many topics around culture and race. So I think whether you're a therapist or someone with OCD, I think you'll enjoy this. Everyone has a culture, so this should apply to everyone. So without further ado, here is Kevin. On today's show, I have Dr. Kevin Chapman. Kevin is a licensed psychologist in Kentucky. He specializes in the treatment of anxiety disorders using CBT ERP for OCD. Kevin is a clinical advisor of the No OCD app and is a sports psychologist for Louisville City Football Club. Welcome back to the show, Kevin.
Thanks for having me. I always like being on the show.
Yeah, it's good to have you back on. And for those that haven't heard the first one, I recommend go listen to it. We talk a lot of general questions around OCD and a bit of sports psychology at the end. So you've done a lot of research studies, and in particular focusing on ethnic minorities and anxiety disorders. So I guess why is that area of research needed?
Well, I think the main reason that area of research is needed, Stu, is because if you think about the diverse populations across the world, certainly westernization of the world in general and the United States specifically, certainly there's a change in cultural roles and such, and culture plays a significant role in the manifestation of psychopathology, particularly in the area of anxiety and related disorders. So actually, since people come from different cultural backgrounds, you can't really necessarily apply these, I guess, homogeneous non-Hispanic white models often to the role of psychopathology in groups and ethnic minority groups and so on and so forth, where culture actually plays a significant role in how people not only present for treatment, but also how anxiety and other symptoms are manifested. It's really, really important, obviously, to understand how those cultural manifestations may take place and what are the barriers to treatment and how those various cultural variables need to be infused into case conceptualization to affect a very good treatment outcome.
Yeah. Okay. Excellent. Good answer. So, in one of your recent papers, I think it was a couple of years ago, you did with a few other people, called Cross-Cultural Phenomenology of OCD, Obsessive Compulsive Disorder. You and your colleagues mention, I think it's in the literature review at the start, around the importance of a clinician's ability to understand the different content of intrusive thoughts because they will differ culture to culture.
Yep.
So I guess my question was, because obviously the core treatment for OCD is behavioral, which is ERP, and in that the cognition's not as important as the behavioral aspect. So I guess, why is it crucial from a clinician's point of view to understand, I guess, the cultural relativity of an intrusive thought?
That's a great point, Stu, and a great question. Because what you find in the research literature is that though across cultures, that OCD manifestation does appear to look a lot alike in terms of the prevalence rates across ethnic minority groups. So, for example, contamination is pretty consistent across populations despite race and ethnicity. You do find that the cultural manifestations of those obsessions do differ. So I guess an example of that would be, like, for instance, if you have someone coming from a low socioeconomic status, or say you have an African American or a Latina coming from a situation where they have a low socioeconomic background, though contamination might be the primary obsession that a clinician may be targeting, it might be difficult for that client or patient to trust the clinician if you're simply using just traditional ERP, saying, well, we need to do some exposure and we need to make sure that we eliminate any and all rituals associated with cleaning or washing. The reason that could be offensive is because it really requires one to be culturally competent and actually assessing the role of culture and what's maintaining those contamination concerns. So, for instance, like historically, we know from the research literature that many ethnic minorities and people that come from low socioeconomic status often have a difficult time with contamination because they've historically been in situations that have been contaminated, right?
Yeah.
So actually understanding why the discuss sensitivity might be high in ethnic minority populations as opposed to non-Hispanic white populations, and understanding that contamination actually represents much more than just traditional diagnosis with regard to OCD. Just having the cultural understanding of that, Stu, and actually shaping up exposures with the cultural sensitivity in mind actually will go a long way for a clinician. So in other words, it's not just as simple as saying, well, this is ERP, so we just apply X to Y. That's not how it really works. Ultimately, we're going to have to be very sensitive to, the maintenance variables associated with why somebody might have contamination concerns that comes from, say, an ethnic minority background, because it actually has some cultural significance as well.
Yeah, no, I didn't think of it like that. That's fascinating. And I guess it's also important from a therapeutic relationship point of view that if your therapist doesn't get your cultural background, it's probably going to be harder to build that connection, and that's going to then negatively impact outcome.
Yep, absolutely true.
Cool. So, so my questions are so small here. Okay, so I guess in the cases where some clinicians don't know the diverse range of things someone with OCD can worry about, and I guess this is a general problem with OCD, that some clinicians just don't get the how OCD will latch onto literally anything. So there's obviously so many obsessions that don't fall in the Y box scale, etc. So I guess should people with ethnic minority be more prepared to justify their thoughts that are less well known?
Yeah, absolutely. I believe so. And I think that's, again, largely because the Y box is not going to capture all the symptom clusters that are endemic to things like OCD. So, again, if we think about like what the Y box is sensitive in assessing, it does miss out on a lot of categories that might be more endemic to cultural or ethnic minorities. So, for example, if you think about scrupulosity or moral obsession, that's something that's not captured particularly well, per se, with the Y box, and concepts within OCD that do cut across many ethnic minorities, such as thought-action fusion, which is something that is definitely relevant to religious minorities, right? So people who have various faith persuasions obviously have a very difficult time with the thought being equal to the action. And that's something also that is hard for many people to understand, because if you think about it, Stu, like if we're an ethnic minority, we have various facets of our identity that may not be tapped into. We might be someone who is also, we have a religious affiliation, so our identity and beliefs might be in God. So scrupulosity might be a manifestation. We might have contamination concerns because we come from a background where OCD manifests that way. So we really have to be very culturally competent and understanding, again, the cultural variables that will influence our response patterns, even on assessment measures like the Y box, which really requires a lot of skill and education on the part of the clinician, and really getting to know each individual client that comes in.
Good point. So what are, in your opinion, I guess from your research, some of the sticking points that kind of face people of ethnicity when seeking treatment or when receiving treatment?
Well, I think the sticking points are would be things like making sure that you ask questions to ethnic minority clients and patients rather than assuming. I find, Stu, like with supervision and like when I've helped other clinicians in the past, that many non-ethnic minority or non-Hispanic white population clinicians, often what you find is that because of their own anxiety, they are afraid to ask us certain questions. Like, so for instance, let's say an ethnic minority patient were to talk about a certain like cultural phenomena or bring up something that's culturally specific. And if I'm a non-Hispanic white clinician and it's uncomfortable for me to ask, then I'll probably try to change the subject or to latch on to something that I do relate to as a way of trying to build rapport with the client. Well, ultimately, ethnic minority populations obviously are going to be much more skilled and adept at picking up on nonverbal behaviors. So they're going to sense that you're trying to avoid a particular topic. So I guess one suggestion and one point of advice is making it very clear that I have to ask questions. If I'm not sure of something related to some cultural specific phenomena, I need to make sure that I'm asking the client or the patient. I think something else is just being aware of the role that discrimination and other cultural variables, sociocultural contexts play into the manifestation of anxiety and related disorders. And OCD certainly is no exception. And I think contamination is a really good example too, because ultimately, like cleaning, washing, and those sorts of ritualistic behaviors that are specific to OCD, those are actually culturally sanctioned behavior in many ethnic minority populations. Yeah. So in some sense, being aware that it's a sanctioned behavior and understanding that subjective distress and impairment are two of the most important criteria when assessing any sort of pathology, understanding and not assuming that that means this person has a ritual. I think you have to really understand it from that cultural perspective to be able to determine if that's something that we need to, modify via ERP. So again, being culturally sensitive, being culturally aware, asking questions rather than avoiding and assuming things, and recognizing the role that sociocultural variables have played into the barriers for treatment for ethnic minority individuals are all very important concepts to keep in mind as a clinician.
Yeah, really good point. In my recent training, I was taught that it's, as you just said, it's okay to be curious and to ask questions because it's better to actually understand and show a bit of naivety than to be ignorant and kind of plow on ahead.
Very true.
Yeah. There was another point I had there, so I just blanked. So is there anything, because obviously in an ideal world, all therapists and clinicians will understand all cultures and have the cultural sensitivity to ask questions, etc. But we don't quite live in that world yet. So is there anything ethnic minorities can do in session in treatment to kind of, I don't want to say spur on their clinician, but make sure that they're getting their point across?
Well, that's a really good question, Stu. I think that, again, in an ideal situation, people will be on the same page. And, the research would suggest, of course, that cultural match is more important than racial match. So in other words, if I can join with a client or a patient as a clinician more culturally, that's more impactful than a racial match, because in many ways you could find that people don't have to match, but be the same race as the clinician for treatment to be effective. That's very true, most certainly in my practice. So with that being said, I think that, one point of emphasis would be, for the ethnic minority clients and patients to be able to make sure that the therapeutic relationship in the context of therapy is a safe place to communicate things like a culture of distress or discrimination and race-related issues. I think being aware that that is absolutely relevant to the manifestation of various forms of psychopathology, and telling the clinician that from the outset is extremely important. Now, of course, when I'm building rapport, obviously rapport is going to be an essential component to treatment outcome. So if I'm an ethnic minority client or patient, it's going to be really important for me to determine whether or not this clinician is somebody that I can actually trust with very intimate information. So in that process, bringing up the fact that we may look different from each other, that we actually may come from different cultures. And like you said, Sue, in your training, like actually being curious, I think that that is a bidirectional relationship. So I think actually bringing up uncomfortable topics, but making sure that race and ethnicity and culture are in the forefront of that discussion is actually going to go a long way with building the therapeutic relationship and influence outcome in a very positive way.
Okay. Yeah, no, thank you. That's good. So is there, because I can say, basically the question is there anything ethnic minority families can do better to support their loved ones with OCD? Because I know where being in London, it's extremely multicultural, very diverse, and that's great.
Yep.
But there are many cultures within that, and the religious aspect comes in as well.
Yep.
And certain families don't want to bring in necessarily therapists, or won't even accept that mental health is a thing. It's a matter for the church or the mosque or the synagogue, etc. So I guess for those more, I don't want to say, because I was going to say, I was going to say structured, but that's not the right word, because I'm then imposing my beliefs on them, but maybe more rigid. Is there any, I don't know, is there any advice for those type of families that can, maybe where it's a bit more taboo and there's more stigma?
Yeah, I guess if I hear you correctly, Stu, I guess what I would say to that would be, ultimately, I think the way family members can support an ethnic minority client or patient, I think that's what you're saying, is to, well, first and foremost, I'm a very big advocate of having loved ones who are supportive, of course, the ones that are supportive, actually during session for the psychoeducation component of treatment. I mean, if you think about part of ERP treatment, it's very important to, when you're incorporating a loved one, for them to understand that reassurance seeking is a very dangerous ritual, and it's very subtle, but it's very powerful. So I'm a huge advocate, if the family member's relationship with the client is strong, to incorporate them into the treatment context so they can be a co-pilot, so to speak, with the clinician, so that they're speaking the same language, making sure they're not providing reassurance seeking. Secondly, I think it's also important for that family member to provide support by actually educating themselves about the nature of the symptomology. Again, many people, and we talk about this on Twitter quite a bit, we basically want to pull our hair out. I shave my head, so I don't do that. But ultimately, we ultimately pull our hair out and get really upset when people say things like, oh, just think about positive thoughts. Or even sometimes we'll say things like, give it to God. And if you're coming from a religious persuasion, we understand that, us folks who, have spiritual lives, what that means. But ultimately, if it were just as simple as giving it, right, to God, or just thinking positive thoughts, I wouldn't be in treatment, right?
Yeah.
So I have to have someone at least that I trust who can help guide me in that direction and actually give me concrete examples of how to do that. So I think a family member understanding actually the symptomology, the symptom cluster, understanding that this affects millions of people throughout the world, that the symptoms actually look a whole lot alike across populations. I think that is really important, that the family member can support the client or the patient in understanding that those symptoms are not a sign that, you're weak or you're somehow less than, that that's something that affects a lot of people every day. And then I think that if they can have some psychoeducation along with the client or the patient, I think that can go a long way too. I'm a huge advocate for incorporating family members, and if we can educate them, then clearly they serve as a cue, so to speak, for the therapeutic context. So, it's really like you're taking your clinician home with you, so to speak.
Yeah, no, I love that idea. And I guess that also relates to anyone with OCD. But yeah, I think that's a great approach. I've never thought about it like that. And obviously maybe this is the more stronger end of the spectrum. But obviously, like in some cultures, it's perfectly normal that mental health is seen as a religious problem or issue, and not one of psychology. And I know I've heard many cases in the UK where various families from sort of Arab countries, India, etc., kind of their parents refuse to let them go to get seek treatment from a mental health professional, and they say they have to go to the again, the imam or the priest, etc. And that's obviously, I don't want anyone to think I'm categorizing anyone. That's just certain parts of those countries, not everyone, obviously. But that's perfectly normal, and I guess we have to respect that's how they see mental health. But we live in, say, England or the States. So if we can, and they want the younger people want to come for treatment, I guess, have you ever had to bring in religious figures into the treatment process? And if so, kind of how did you do it?
Yeah, well, I'll say this. There's a couple different facets to answer that question, Stu. I think that first and foremost, there is research out there. My colleague and friend, Dr. Monica Williams, she's someone who is well aware of that literature as well. And basically, there are many treatment studies where people would actually train clergy and members of the clergy as extensions of the therapeutic context. Obviously, that requires the clinician to build good rapport in the community, which is a completely different podcast. But ultimately, being a clinician who has a good relationship in the community with members of the clergy is a very, very, very effective way to help ethnic minorities or even cultural minorities in that way, who certainly have religion as a strong part of their identity, and to be able to navigate family systems and such, is to actually educate members of the clergy about those symptoms. This is something that's very important in the scrupulosity literature as it is that, a clinician who really understands the religion that they're actually helping treat, then I think that ultimately that's going to provide you with more credibility as a clinician anyway, to be able to help people who are of different religious backgrounds who struggle in the area of scrupulosity, because that gives you the ability to determine whether or not something is culturally sanctioned within the religious context, or if that's something that is actually really ritualistic. So part of it is educating members of the clergy. Secondly, though I've not incorporated people like priests and others in the community within the treatment context per se, I definitely have been involved in the community where we actually were to take essentially the treatment options to them specifically. So being able to, a big thing there too is clinician's responsibility to really be deemed competent to the members in the religious community. And in that regard, they will be much more receptive to the quote unquote psychology, which is often construed as demonic, often construed as something that is new agey. But if you're a competent clinician that also understands the various religious tenets and such, then they'd be less likely to stigmatize, ERP and other CBT concepts, and be more likely to receive you with open arms and be more flexible in their approach. So psychoeducation to the members of the clergy is essential, and it's definitely possible.
Yeah, absolutely. So good answer. So in terms of people of ethnic background who want to, find the right treatment provider, I mean, this is an assumption, so correct me if I'm wrong, but I'd assume that, for example, if I'm an African American, there's a good chance I want to only work with an African American therapist. Or the case of an Indian in the UK want to work with an Indian therapist. And you mentioned earlier about culture being more important than sort of race. So if that's the case, well, is that kind of true, the assumption that I said? And if so, is it more important that people look for the cultural understanding more so than the racial similarities?
That's a great question, Stu. So really the first part of your question is yes and no. And the reason I say that is because that actually is a great point. And the point I think of this podcast is, this particular podcast, is that we have to acknowledge that there's so much heterogeneity across racial groups that it's really hard to say whether or not they're going to necessarily seek someone who's a racial match. I think, in fact, many people say, let's use African Americans as an example, depending on how you perceive yourself culturally, you may not be that concerned with the race or the ethnicity of the clinician that you're seeing. But if you have a very strong African American heritage and background and associate almost exclusively and culturally with our other African Americans, that may be accurate. So ultimately, it depends on the clinician's ability, right, to really know and understand that people racially, of course, are going to vary extremely because of the heterogeneity across cultural and racial groups. and who they seek. So, so the answer to that is kind of yes and no. It depends on my own personal identity and how much I'm affiliated with my culture of origin. So with that said, you'll have a large group of people who most certainly will seek same race therapists. And on the other hand, you'll have someone who I guess has been much more acculturated in some degree, who will find somebody that they're just comfortable with, which could be cultural in nature, or it could be somebody that they deem as just an expert in that area. Yeah. Does that make sense?
No, it does. Yeah, absolutely. I guess my motivation behind the question was I don't want people to put off seeing a therapist because he or she may not match his or her culture or race. Yeah. So I almost want them to think, if you can and you want to find someone of your own race or culture, great. But if that's not available, find anyone kind of attitude.
Right. Absolutely.
Yeah. Okay, cool. No, good answer though. The one thing that came up in some of my research was, for example, people from China if they go to their GP, their doctor will talk about in the case of depression anyway, will talk about symptoms somatically. So they talk about how they're low energy, etc., etc. Whereas someone of a Western background would talk about more psychologically in their symptoms. And I guess, is there anything that you've noticed in people of different ethnic backgrounds and how they present to you?
Yeah, that's a great question, Stu. And yes, I definitely would corroborate that literature. In fact, much of my own research in the past has corroborated and supported that line of work. And what you find, there are a number of different hypotheses as to why the finding that ethnic minorities across the world tend to somaticize symptoms of psychopathology more so than, and have a psychological description. And one reason for that is because there's historically been a stigma associated with mental health. So it's much easier and much more socially acceptable for me to describe my symptoms in physical terms because it's less stigmatizing, right? So that if I have stomach ailments and I have distress and my heart's beating fast, or quote unquote, my nerves are bad, is certainly a historical term with folks from low socioeconomic status in the United States and African Americans historically. Yeah. That implies something's physically wrong with me, which is way less stigmatizing historically than something is mentally wrong with me. So part of that is that piece. The other piece, I guess, would be more so the mind-body connection and ultimately attributing the causes of various forms of anxiety and related symptoms to much more physical things in nature that are much more biologically based. And that goes along with the initial response that I had, is that it's historically been way less stigmatizing, right, to say that something's wrong with my body as opposed to something that's wrong with my mind. So that finding is consistent, and that's certainly been found in a plethora of ethnic minority groups across the world, actually.
Okay, no, that's fascinating. I didn't realize that. Okay, so I guess what does the future hold for this area of research? Well, I guess
that's a good question.
Yeah, where are you kind of interested in if you're still researching in it?
Well, I think what's big in this area, Stu, honestly, is putting culture, race, ethnicity, etc., all cultural variables, infusing those variables in the case conceptualization. I think that as researchers, scientists, and practitioners, we've, for the most part, historically, we use words like dearth and paucity when describing the research status with ethnic minority populations. And that's because traditionally there's been a stigma associated with mental health in most ethnic minority populations. And therefore, we have not presented for research studies and such because there is actual data to suggest that ethnic minorities will be mistreated in the treatment context. So it's a historical problem, right? So with that said, typically we've used these extremely, I guess, European American based models on all people and have tried to get people to fit into those conceptualizations. And what we now know is that culture is extremely important and has a whole lot to do with the expression of psychopathology. So ultimately, I think where the literature is most certainly going is though treatment and symptom clusters are consistent across people, that's a fact empirically, how that is infused into the treatment context is culturally specific. So being able to conceptualize a case with culture, Stu, in the forefront of the case conceptualization is going to be a win-win, not only for the the client or patient, but most certainly for the clinician. So being able to put culture in the forefront of case conceptualization and altering and modifying treatment to meet that person's specific needs is literally our call and our charge as clinicians anyway. But getting more people to recognize that and be culturally competent is most certainly, hopefully, the wave of the future, being the rule, not the exception.
Yeah, no, I love it. Yeah. Okay, so towards the end now, what if you could pick up the phone and call the 20-year-old Kevin, what would you tell that young man?
I would tell Kevin to start taking his own cultural experiences and taking all the experiences he's had, not only acculturation experiences, like being socialized into kind of the global United States Western culture, but also my enculturation experiences, which are specific to my African American heritage. And I'd say all that's going to be relevant in 20 years. Like that's going to be something that's going to be very important and will make you a much better clinician. So make sure that you keep your ears to the wall and recognize the importance of culture as you contribute to society in that way, and know that everybody's not the same. There's a lot of heterogeneity with people, and your experiences are going to help dictate how to effectively manage some symptoms that people may manifest when they see you in the future.
Yeah, I love it. All right, and seeing as we talked about religion on this podcast, if heaven exists and if you believe in it, let's use it as the theory for now. You get to those pearly gates or whatever it is, and God speaks to you. What do you want he or she to say to you?
I would hope that God says to me that you've been a good and faithful servant, and you most certainly have expressed the love that I have for you to everybody that you've encountered in your lifetime. And that is the number one thing that I want to hear, is that I was a faithful servant and I did everything that I could to express love to everybody that I encounter, and that I was able to help every person that I interacted with.
Yeah, awesome, man. And is there anything else that I haven't asked you that you wish you could have shared on this topic?
No, because you had a segue about the transdiagnostic approach that we can have for part 3 whenever you I think it's interesting too, because I actually alluded to some of those concepts in the first podcast that you and I did together. We talked a little bit about what I call associative learning and inhibitory learning. That's actually part of what the transdiagnostic approach is really getting at. So certainly being able to talk about that at some point in the future will really be. Other than that, no, I think you did a phenomenal job asking questions. Really, cool. Hopefully I answered them correctly. No,
you did a great job, and thank you. And we'll leave that as a teaser for part 3 sometime. And always thank you for coming on and for sharing your expertise in this important area, and allowing my naivete in areas. So thank you.
No, I appreciate it too. I look forward to hearing this podcast, and I look forward to talking again in the future, my friend.
So there you have it. I hope you enjoyed my chat with Kevin. I certainly learned a lot. And quick disclaimer, this podcast is not therapy, it's not a replacement for therapy, and nor should it be. Please seek treatment from a trained professional. And until we speak, take care, guys, and thank you for listening.